This presentation is on two common knee patterns commonly encountered with sacroiliac joint dysfunction. When someone sustains an injury to their body, it often involves more than one region of the body. And also, we need to acknowledge, of course, that clients bring in their history in their body, and previous injuries to the knee could certainly accompany a new injury to the low back or sacroiliac joint. And one pattern that I see in this patient population is a pattern in which one knee is maintained in a slight degree of flexion relative to the other knee. And there will be greater space when you go behind the knee. Just to orient you, this is the lower leg bone, the tibia, and the fibula, and then this is the femur. Patella is deep to this tendon and ligament. And so a knee that maintains slight flexion will have a lack of spring mobility when we push the lower part of the femur posteriorly. And because the knee is bent, then that causes stretching of the patellar ligament and patellar tendon, and therefore when the knee is stuck in that position, the patella will be hypomobile. It will lack left to right mobility. And this knee pattern will actually have a greater amount of knee flexion compared to the other knee. When you try and lift the lower leg to create hyperextension, it will slightly lack hyperextension relative to the other knee. And this also affects muscle function and can inhibit the hamstring muscles. And I have noted that sometimes a client will present with greater laxity, what appears to be laxity of the ACL, with an anterior drawer test to the tibia. But upon restoring normal extension, it seems to reflexively increase muscle tone of the gastroc muscle group and also the hamstrings, which cross the back of the knee and add stability to the knee, because I find a reduction in that anterior drawer, anterior cruciate ligament test. Treatment is very straightforward. I use 2" by 4" by 8" foam, and I place one on the tibia close to the knee, and then I take another one and I place it down below the ankles, and then I simply engage the distal femur and glide it posteriorly, and I maintain that for 5 minutes using just a mild amount of force, just enough to engage the joint and soft tissues, and do that for 5 minutes. And oftentimes that's very effective. For a home program, you can have them do the same kind of positioning and put a 5-pound weight above the knee. So now we'll talk about the opposite kind of pattern that we see sometimes in this population, and that is where someone has sustained an injury that causes the distal end of the femur to be stuck in posterior glide. And in this population, when you compare side to side, you'll note that this femur is deeper on this side. In this case, it's the right side. That it's deeper when palpating the top of the distal femur. And it will also lack posterior glide spring because it's stuck at end range of posterior glide. And realize that gliding is part of normal knee flexion and extension. There is a glide, an anterior and posterior glide motion that occurs. But in this example, through trauma, the distal femur is stuck in excessive posterior glide. And when you lift the distal part of the lower leg, you'll notice a greater amount of hyperextension because the knee is already hyperextended. It gives a greater amount of hyperextension range of motion relative to the other side. When you test flexion at end range, you'll notice a reduction of flexion in this knee. And this pattern can also cause inhibition of muscle function, including the hamstring muscles. And please realize that's a secondary stabilizer muscle to the sacroiliac joint, because in 30% of the population, the hamstring tendon of the biceps femoris muscle attaches directly onto the sacrotuberous ligament and adds tension to that ligament, adding stability to the sacroiliac joint. So this population tends to be a little more symptomatic than the other population that we spoke of. And treatment is very straightforward, and it's typically very long lasting. And what I do to glide this femur, let's see, okay, so now it's positioned in posterior glide, and to restore anterior glide to that femur, what I do is I stabilize the lower leg with my right hand, and then I weave my forearm underneath the distal femur, and I latch onto the other leg with my hand, and I simply lift up with my forearm, and I maintain that pressure for 5 minutes using a digital timer. And I have no history of having to ever treat someone more than once with this treatment. It's very effective. It frees up the patella, and the reason the patella lacks mobility is because it's sucked downward. It's pulled downward with that posterior glide. And treating it restores free patellar mobility and restores anterior to posterior spring with recoil of the distal femur, equalizes knee hyperextension, and tends to equalize flexion as well. And so these are two patterns that involve the knee joint that we see somewhat frequently in the population of people who come with a diagnosis of sacroiliac joint dysfunction. And of course the next joint is the hip, which has a profound influence on pelvic posture and mobility. And the next joint after that is the sacroiliac joint. So we're only 2 joints away when we're working on the knee joint. And I hope that this has been helpful to you and informative and gives you some treatment ideas. And I hope it helps your patient population and person suffering with SIJD and knee pain. Thank you very much. And this is Hesch Institute. I'm Jerry Hesch, Doctor of Physical Therapy in Aurora, Colorado. Feel free to follow us on YouTube. And the website is www.heschinstitute.com, and Hesch is spelled H-E, S like Sam, C-H. Thank you very much.